Good afternoon. Good evening, everyone. It's Pouria Moradi doing Facebook Live for Plastic Surgery Hub. So we've had some technical issues getting the iPad up and running, but now we're good. So we've got some questions to answer today. So if you want to put all your questions in, and I'll answer them, and we'll start with some of the questions that have already been asked. What is your opinion on breast implants to use, especially with all the recent controversies and concerns with textured implants? I guess that is a very controversial question. My thoughts are this. So you got to look at implants and all the different types of texturing you have. And the different grades of texturing. So you've got the macro textured implants, and they've got different classifications, but it's all a bit arbitrary, really. And you've got the old Allergan ones, which are very rough, and you've got the polyurethane, which are also rough. Then you're working down to the micro textured, which people are probably used to, the Mentor implants, which are micro textured. Now, the implications for ALCL are with the latest data with the micro texturing is 1 in 80,000, 85,000 with the Mentor, and with these ones up to as high as 1 in 1,000. So that's why they've been recalled. And I only use them in the rooms as historic references. And then you've got smooth implants, and smooth implants, as the name suggests, are smooth. And you've got the traditional Mentor smooth and other companies, and also the Motiva smooth, or nano textured, which I prefer. And that's all the fuss about texturing. Now, historically, the reason texturing came in was that it was thought that it was going to help with capsular contracture. And has it? Probably not, particularly nowadays with modern techniques, our understanding of biofilm, our understanding of antibacterial coverage for implants. In fact, the texturing probably creates more of a capsule, and that capsule is what is implicated in ALCL. The issue with smooth implants is that they produce less of a capsule, which means less support for the implant, which means that it's got more chance of displacing, usually down and out. So that's why that's the texturing debate. Now, you can't get smooth implants in anatomical yet in this country. Motiva are working on anatomical implants that have tabs to stop the rotation. In my opinion, I don't think it's the texturing that stops the rotation. I think that the texturing creates more capsule so that the implant is more snug within its pocket because it's got a thicker capsule. Hopefully that makes sense. Let's answer some more questions, which we've got here. What is the best placement of implants? I'm just so confused about whether behind or in front of the muscle is best. Everyone seems to have a different opinion. Does the scenario differ with each patient? Yeah, I think it definitely does. So the implant can either go in front of the muscle or behind the muscle. I think that's all you should really think about. There's different terms such as subfascial, hybrid subfascial, subglandular. All those are variants of going above the muscle. And then you can go under the muscle. And there's different variants of going under the muscle. You can go dual plane 1, 2, 3, or 4. There's all different styles. But I think as far as patients should know, you're either going above or below the muscle. The pros and cons, above the muscle is less painful because the pec muscle, where we incise the pec muscle, lift the pec muscle up and put the implant like this, gets more spasm post-operatively. It takes a bit more time to recover, get back to exercise. Above the muscle can look faker because you don't have the pec muscle squishing down the top of the implant, so that you get to see the roundness or the fullness more when you go above the muscle. It's never really been studied, but in my opinion, one of the problems with above the muscle, I think it ages the breast more because it exerts a force on the breast tissue that can thin the breast tissue out. But when you go under the muscle protects any force on the implant. And under the muscle is more natural and I think has a longer benefits. Hopefully that answers that. So now, can you go above or below? The decision process historically has been if the upper pole you can pinch about 2 centimeters, then you can go above the muscle, okay? Because you've got enough soft tissue coverage in the upper pole to camouflage the top of the implant. But I personally would never put a traditional smooth implant above the muscle in a thin lady, because you see all the rippling that these have, and then you get that horrible rippling. So if you're going to use the traditional smooth round implant that ripples a lot, I'd go below the muscle so the pec muscle can cover the top of the implant. Now, what is dual plane? Dual plane just refers to the fact that when you're putting the implant in under the muscle comes up like that, right? And then you divide the breast gland off the muscle, so depending what sort of dual plane, more of the breast is in contact with the implant, so the bottom half of the breast is in touch with the implant to get more influence of the implant, and the top is under the muscle, so dual plane. The top half under the muscle, the bottom half under the gland. Here's a question. How long do you think they last? Would they last longer under or above the muscle? Yeah, good question. I think, my opinion, as I said before, I think above the muscle ages the breast more. There's been one MRI study where they looked at the atrophy of the tissue above or below, and when the implants are below the muscle gets atrophied, but the breast gland doesn't. When you go above, the breast gland gets atrophied. So I think above the muscle over long term may age more, but that's just my opinion rather than anything else. If you have to move your nipples, can you choose how big and what they look like, or is that up to the surgeon? I think any nipple movement is part of a breast lift. An isolated nipple move is hard to do. The nipple does move by itself when you do a breast implant alone, so sometimes you get an assisted lift with an implant alone. But when we do move it surgically as part of a breast lift procedure, whether you do a periareolar lift, which just means an incision around the areola, or you do the vertical lollipop, scar around here, down like that, or when you do the anchor, so scar around the areola, scar down here, scar across here, you still have to move the nipple. All surgeons use a template whenever we move the nipple, and think of it like a cookie cutter. It's like a round disc that we use. I personally like using a 38 millimeter and sometimes a 36 millimeter diameter. Others use 42 millimeter diameter, but it all is relative to the size of the breast. So if you've got a small breast, you want a relatively small nipple. But if you've got a large breast, you want that areola complex to be a bit wider, because it just looks better on the meridian of the breast. Whereas if you have a really small areola on a really big breast, that looks funny. And conversely, a really big areola and really small breast looks poor as well. So you template and customize it to the breast that you're trying to make, the future breast you're trying to make. Okie dokie. What are the best shaped implants to get cleavage, round or teardrop? I think creating cleavage, round and teardrop can create the same cleavage. You can argue which is better, round or teardrop. It's all depending on what the pre-op breast shape that you have. Okay, so what I say to patients is a round implant can look natural in someone that's got a natural breast to start with, and then a teardrop implant can look round if you've got totally flat chest and you put a teardrop in, then they look fake and round. So I think round and teardrop, depending on the uses, can create the same cleavage. You create more cleavage by getting the implants to sit closer together. So you can get them as close, like you don't want that, you want them like that. But also you can create cleavage by projection. And projection, you can either have a moderate profile implant, moderate plus, high, ultra high. It's how far it projects out from the body. So the further projection you have from the body, the greater the cleavage. So I think round or teardrop give the same cleavage, in my opinion. You can create more cleavage by getting more projection or profile of an implant. Here we go. I want natural looking and feeling breasts. Will fat transfer help to make them feel more natural? And how much more expensive is it when you get fat transfer implants? It varies. Can I go bigger further down the track? Okay. Lots of questions here. So let's start with the first one. I want natural looking and feeling breasts. Will fat transfer help to make them feel more natural? And how much more expensive is it than implants? Well, I can't talk about price, but yeah, fat transfer will make it feel more natural. I think it's the whole fat transfer thing. I think fat transfer as a primary breast augmentation can only give you very marginal gains, because if you put a 300cc implant in, you've increased the volume of the breast by 300cc. It's predictable. But if you put 300 cc's of fat, half of that doesn't survive, so you've only got 150 cc's, and of that 150 cc's is distributed, in certain areas of the breast, so it's not the same as putting a 150 cc implant in. So in my opinion, fat should only be used in breast, whether it's breast reconstruction, breast lift, breast augmentation, as an adjunct to something else. So if you've done a lift and you just want a bit of fat to help with the cleavage or get some lower pole, then great. If you've done a breast implant and you just want to soften the cleavage across here and do what's called a hybrid breast augmentation, where you put the implant in, you use a slightly smaller implant, and then get fat and inject fat into the cleavage, or if you've got risk of double bubble, you can put a bit of fat in the double bubble. It's a good way to hide the implant to make it more natural. Kelly Henderson. Hi, Kelly. Where do we go? Can I go bigger further down the track with more fat injection? Yeah, I think with fat you kind of have to have multiple sessions, because let's say you want 500 cc's in a breast. You can't put 1,000 cc's of fat into a breast, because whilst most of it won't survive, what you don't want to happen, if it doesn't survive, it absorbs, great, but what you don't want to happen is if you overfill with fat, then you get fat necrosis and little globins of hard lumps all throughout the breast. So you can't keep putting fat in. There's only a certain amount of fat you can do in one sitting, but you can do multiple sittings if you want to get to your ultimate goal. The thing is, you need to be able to liposuck that much fat out as well, which is not as easy as it sounds. Will the operation cost the same as the first one? I mean, cost varies between surgeons and their policies, so we won't go into that. What do you think of fat transfer? Well, I think I've answered that. Do you do it? Yes, I think I've answered that. What's the recovery like with an implant fat transfer? I think the recovery depends how much fat you take and where you take the fat from. From when you do a breast implant, it's the usual recovery. Usually when we do fat transfer, we get fat from redundant areas. Don't think of it like liposuction, where we do global fat reduction. We're just trying to cherry pick areas of fat so we can get the good, wholesome fat that we can use. So usually the liposuction site is the inner thighs or the love handle area, because that's the most reliable source of fat and also the best donor site, so you don't get as much contour issues. Okay, we've got a question. Oh, wait, I got it. Here we go. I've had implants for 14 years that are due to come out. Question, should I get new ones or will I end up with flat chest again? Yeah, I guess that's a good question. It really depends on how much breast tissue you have now. A lot of patients come in and go, look, I had my implants done 14 years ago. I was totally flat chested. I had 300cc implants in. But, in 14 years, we all change. The breasts change. You may have been pregnant. You may have put on weight. You may have lost weight. You may have breastfed. So it's hard to know whether they'll go flat-chested, because I think in that time you may have grown more breast tissue. Hormones change as well. So will you go flat-chested? It's really hard to know. The best way to obviously get examined by if your surgeon, if he or she's not still operating, then someone locally or someone that you trust, and he or she can examine it for you. But why do you need to get the implants out? You've written here they're due to come out. I think it's one of the biggest misconceptions is the patients, and I saw actually a patient today who said, I've had my implants in for 10 years. I've been told I've got to remove them every 10 to 15 years. That's totally false. If you've got no problems with your implant, then you don't need to get them out. So why do you need to take your implants out? There's really only three reasons. Personal preference. I want to go bigger, I want to go smaller, I've had enough of implants. 2 is if you've got capsular contracture. How will you know if you've got capsular contracture? The implants go hard. You can't get a scan, you can't get an MRI. If you feel that the breast implants have gone hard, then that's a capsular contracture. That's why you need to get them changed. And then lastly, if you've got a rupture. Now, majority of form-stable implants, if the shell is ruptured, they don't leak anywhere, so the shape of your breast may not change. So if that's the case, then you can get an ultrasound or preferably an MRI, and that could assess the integrity of the implant. So in summary, do you need to get your implants changed? Yes, if you have a problem, capsular contracture, rupture, or you want them changed. But you shouldn't change them for the sake of changing it, because that's an unnecessary surgical burden on yourself. We got a good question. What about redistribution after transfer? The patient that wrote that in, what about redistribution after transfer? Do you mean, where does the fat redistribute? Well, I'll try to answer that. I think what you're trying to ask is, if you get liposuction, say in your love handles or your inner thigh, will you put on fat elsewhere? All the studies that have been done on global liposuction suggest no. You put less and less fat on in those areas because you've removed all the fat cells, okay? The fat cells that remain may get bigger over time, but the ones that you've taken won't come back. So you shouldn't get redistribution of fat elsewhere. Now, if you put on weight and lose weight, if you transfer fat to your breast and then you end up putting on weight, losing weight, then you'll preferentially put on fat there as well, because it's viable living fat. Somebody wave. Okay. With a breast lift and implant, do you believe it's better to go 2 separate surgeries or get it done in one? Yeah, that's an awesome question. So breast lift and implant, two operations or one. I'm a bit biased on this. I think where possible, always go for one. And here's the reason why. Breast lift, you're trying to make the breast smaller. So that's pretty straightforward. Breast implant, you try to make the breast bigger. So you're doing 2 contradicting operations in one. You're trying to make something smaller by doing a lift, but also trying to make something bigger by putting an implant in. So what I say to patients is, if you have a lift, it's easy. You just do a lift and make it nice and tight. But if it's too tight, you can't put an implant in. So you have to do your lift based on which implant. So a lift for this big implant is going to be different from a lift from a smaller implant, because I'll do less of a lift with this, less of a lift with this, and more of a lift with the smaller implant, because you've got to make it tight. Now, once you do that, there's a chance that once the breast, if you go too tight, the wound breaks open. If you go too loose, it sags. So you do it what's appropriate at the time for that particular implant, but it may sag afterwards. So you need a second bite of the cherry. So some very good surgeons worldwide and in Sydney would stage the operation, do the lift first, which is 1 2-hour operation, wait 6 months, and then do a second operation for the implant. But that's 100% chance of 2 operations. So what I say to patients, that's 100% chance that you'll need a revision. So 2 operations. But if you do it in one stage, depending on the complexity of the operation, depends on what the revision is. Now, if it's a simple breast lift and implant, I say, well, the revision rate is anywhere between 5 and 15%. If it's a more difficult one, I say, look, it's about, the risk is 20 to 40% of needing that second operation. And then there's some cases that you know are going to have a revision, and in those cases, it's a sensible conversation of, well, this is a very difficult case. The difficult ones are the patients that have very heavy breasts and a lot of breast below the crease. It's really hard to lift the breast arm, hold it there, and then put a heavy implant in. So those ones have a 50 to 75% chance of revision, which I still think is better than 100% chance of revision, but you have to pick the patients. The easiest lift and implant are when it's really just deflated, very little breast tissue, just a lot of loose skin. They're good. The heavy breast lift implant cases are the hard ones are the ones that very dense, heavy breasts, because it's really hard to keep that up and put an implant in. So in summary, I'd always go for one stage because that's better than two. Realistically, how big can you go with fat transfer if you begin at an A cup? I don't think you can go that big because fat by itself doesn't create that much shape. It just gives you a little bit of volume and it's unpredictable. Now, one of the problems is if you are an A cup, chances are that you probably are pretty lean and you're not that fat, but you don't have subcutaneous tissue to start with. So where are we going to get the fat from? So the most we like to inject in each breast is about 250, 300 grams. So let's say we do 250 on the left breast, 250 on the right in one sitting. So that's 500 cc's of fat. Now, if you're an A cup, you may not have 500 grams of fat to liposuck. You will have it over the body, but you really need to go all over the body to try to find 500 cc's of fat. And then once you've done that, then you're injecting in of the 500, 250 each side. Chances are 150 to 200 is probably going to take. So it's pretty unpredictable how good a response you're going to get. So if you're an A cup and you want to go a bit bigger, you probably in one sitting will be lucky to get to a B. Then you might need a subsequent sitting in some time. So for me, fat by itself isn't predictable, and it's really hard to convince someone to do an unpredictable operation. What you'd rather is use a smaller implant and then use fat to give you a bit more of that natural result, which is that, the hybrid breast augmentation, because you're doing half-half. So hopefully that makes sense for you. And you can't get much shape. So if you're proper A cup and you don't have much shape, it's hard to create shape with fat because it's only fat. It's not going to create shape. Do you have a rough price for guide for fat transfer? We do. So if you want to email Catherine, so if you just email info at Dr. Moradi, so drmoradi.com.au. I couldn't tell you. It just depends how long you are in the operating theatre, whether it's 1 hour, 2 hours, and where we need to take the fat from. So hopefully that will help that question that was just asked. Okie dokie. How do I know what size is right for me? I've seen some ladies who have had the same size implant put in, but they look different on each of them. Yeah, I guess all my patients that have seen me kind of know my little analogy that I use. Thanks, Susie, for putting that email in. Fantastic. So what I say to patients is, obviously everyone's different. We all know that. Think of it like building a house. Building a breast is like building a breast is like building a house. So when you build a house, you need a parcel of land. So your chest wall is your parcel of land. So if you've got a chest wall that is 400 squares, you don't want to put a small house on there. You want to build a house that matches your chest wall. Now, if you had a big chest wall and put a small house, it looks funny. But if you had a small chest wall and put a big house, it also looks funny. So first, your surgeon will go through measuring. Okay. Now, for me, I'm pretty aggressive with my measuring. I really get the whole width of the new implant, the new breast. So you get it from where you want one cleavage to one cleavage, measure it out, 13 centimeters. So then you've got your width. Then you can create volume with projection. So using the house analogy, if you've got a parcel of land that's 200 squares and you want a 400 house, you go 2 stories. Or you go 3 stories if you want 600, 4 stories if you want 800. So that's when the profile of an implant comes in. So you can have a moderate profile. I'll try and find some implants. So you can have like a moderate profile, a moderate plus, which is like a 2-story house, so it's just got a bit more projection, and then you go high, ultra high. Different companies call it different things. Some call it profile, some call it projection. So you've picked your width, then you create volume with projection. So then once you've got your chest wall measured out, then different patients have different chest walls. So you could be a patient with, this is the catalogue, you can be a patient with an 11 centimeter chest wall and go for a high profile implant of 315 cc's. That's going to look very fake on you at 315 cc's, but you're only 11 centimeters. But let's say you had a chest wall of 14 centimeters and you put that same implant in, it's too small for your parcel of land. So that 315 is going to look way different on someone with 11 centimeter chest wall compared to someone with a 14 centimeter chest wall. So we want to create the width. So I say to patients, I've had patients come in that want the supernatural look and they're really wide, up to 13 centimeters. And I said, look, you need a 360 cc implant. And they say, well, 360, I really wanted like under 200. I'm like, well, if I got under 200 on the catalogue here, here we go, 200 cc, it's 10.75 centimeters. So you're 14 centimeters, you want me to put a 10 centimeter width implant, that's a guarantee that you're going to have gap here and no side boob. And in fact, the goal was to look natural, but it ends up looking unnatural because you've got a big gap. So depending on the patient, if you're 5'4" and a width of 11 centimeters, 300 cc's is going to look pretty big on you. Whereas if you're 5'10" to 6 foot, putting a 300 cc just doesn't fill out your parcel of land. So I think that's where the customization comes involved. So I think for me, choosing an implant's pretty straightforward. Go width, get the width of the breast, and then if a patient says, I want to look supernatural, I don't want anyone to know, so that's when I use a mini or moderate profile implant. If they're like, you know what, I'm going through this, I just want to get more volume, a bit more cleavage, I don't want it to look fake, but I'm going through this, I want something, that's easy. Then that's a moderate plus or a demi in the Motivas. And then high profile is, I want the fake look, I want to be noticeable, and then that's a high profile with a full look. Ultra high profile you would never do in the first sitting. And that kind of simplifies things. You pick your width, and if you want subtle, go for moderate. If you want kind of in a natural full look, you go to moderate plus. If you want the fake, go high profile. And whether you go teardrop or round, probably doesn't make as much difference as you think it does, because a high profile teardrop looks fake, whereas a low profile round looks natural. So we got a good question. How common is implant rejection? I guess it's a definition of rejection. So when patients say, I lost my implant, my body rejected it, the body's not rejecting the implant. You've probably had an infection, and the infection has rejected the implant. So that's why we're very fastidious and strict about antibiotic prophylaxis. Have an antibiotic before you go to sleep. We wash the pocket out with antibiotics, change gloves, total sterile technique, using a Keller funnel if needed. So the body rejects any foreign object, the knee replacement, hip replacement, pacemakers. Not that the body just rejects it, it's because the body's got an infection and the body's trying to get rid of the only way the body can get rid of the infection is getting rid of the foreign body, because they have bacteria like to stick on implants. The other reason you can reject an implant, if you just put too big an implant in the pocket and it doesn't heal because there's too much stretch on the tissue. So the analogy I give to patients is, you've got a garden path and the garden path wants to heal, but everyone keeps walking on the garden path. So you make your incision to put an implant in, or you do a breast lift, it wants to heal, but if you've got too big an implant, the body can't heal it because you've got this constant force from the implant. I'm a deflated A cup. Do you then recommend an implant and fat transfer to the most natural look? Oh wait, I don't want to go big as I have small lean frame, but really just want shape and volume back. Yeah, okay, so just to read that question again, deflated A cup, the question is, do I recommend implant and fat transfer for a more natural look? I don't want to go too big. For me, keep it simple. natural look is the mini or moderate profile implant. So if you want a natural look, go for the natural moderate profile, depending on your width. So let's say, hypothetically, you had a width of 11 centimeters, that'd be 220 cc's. If you had a width of 13 centimeters, it would be 360 cc's. Both will give you a natural result because you're using the mini or moderate profile implant. Would I recommend fat? I wouldn't. For me, I mean, fat's like, it's good, but it's extra cost, and so if you want to spend money, fine, spend money, but it's an extra cost, longer anesthetic, and you use it if you need to use it. If you're really bony chested here and you need to soften that cleavage in that area, if you're at risk of double bubble, and you put the fat to try to camouflage the double bubble. But I only use fat as an adjunct to try to prevent something, because there's the what would you do and what could you do. You could do anything, you could put fat, you could do this, you could do that, but what would you do in the practical sense, in a practical, realistic world, is do the safest, quickest, most predictable operation, is put a natural implant in, whether it's teardrop or round, doesn't really matter in my opinion, but use a moderate profile implant to get you the natural look. Here we go. Whoop. You should make a short YouTube video with this sizing discussion. Oh, thank you. I spend so long talking about it. It's probably not a bad idea. Yeah, okay, I'll do that. That's actually a really good idea. Do people still watch YouTube? Okay, cool. I'll crack on. I had 350 cc's put in 5 years ago. I'm ready to have them removed. I've been reading up whether or not I should get on block. I don't really understand what it is. Can you explain it? Tell me what you would and wouldn't recommend on block. Some are so adamant on another group I'm on, and I've spoken to a surgeon who said it's not necessary. I'm confused. Okay, so I wish I had. I don't have a prop. Anyway, what is so? If you want to get whenever you put any foreign body in your body, hip replacement, knee replacement, implant on patch, women get for contraception, or a breast implant, the body recognizes, or an ingrown hair, that's the best example. The body recognizes it as a foreign object, just as an ingrown hair is a foreign object, because ingrown hair is supposed to be outside, but when they curl inside, the body freaks out. And what does it do? It blocks it off, creates a cyst around it, a synovial cavity around it, no different from a breast implant. So the body creates a capsule. Everybody gets a capsule. You can't not have a capsule. Motiva report, whether you believe it or not, that their capsule is thinner than the others. Anyway, that's their sales pitch. It could be true. Anecdotally, I do agree with them, but that's for a different day. So everybody gets a capsule. When you have problems over time, that capsule may contract around an implant. You've got the implant here, you've got a capsule. Over time, that capsule may go hard. You get calcium deposits, and you get a hard capsule, coolest, okay? Now, whenever a patient gets a proper hard capsule, capsular contracture, we then do an en-bloc capsulectomy. So if you go on my Instagram page, on one of the videos, it shows a full total capsulectomy, an en-bloc capsulectomy, because the implant's sitting like this and you've got this ball of calcium or capsule around it, and you do an en-bloc capsulectomy. It's very straightforward because the capsule is thick, because you're removing the implant because they've gone hard over time, right? So you take the capsule out with the implant, and you do it en bloc because that's actually, frankly, it's easier doing it en bloc because you just go around the capsule, everything comes out, implant go away, then you either replace the implant or you don't replace the implant and leave it, or do a lift, or do whatever you feel is necessary. So that's an en bloc capsulectomy, okay? Now, why en bloc has become like the new cool term that people are using is because of breast implant illness. So whether you believe in breast implant illness or not, it is unknown. I've got the latest research paper in my drawer that I read over the weekend, and all the best available evidence suggest that it doesn't exist. But that is being naive, because there are thousands of women on groups that claim that they do have it. So I think there is a happy medium somewhere, and we need to know more about it. Now, why people are saying doing a total en-bloc capsulectomy if they, for ALCL and for capsular contracture, absolutely, you do it. But for breast implant illness is where the controversy comes, because firstly, the science at the moment is in its infancy. Well, that's not true. The science on connective tissue disorders and autoimmune has been around for the best part of 40 years, and it's said it doesn't exist. But breast implant illness is a new phenomenon that people talk about, which we can't ignore. And in that, they say, well, once you take the implant out, you also need to take the capsule out. The problem with that is that if you've got a new implant and you've got a paper-thin capsule that hasn't formed yet, taking that off can cause way more harm than good. So back to that capsulectomy, when you've got a thick capsule, it's a thick capsule. It's really easy to take out, okay? Now, if you've got an implant that's got a super thin capsule, and if you're above the muscle, it's not a problem. You can take the thin capsule out on top of the muscle. But if you've got an implant below the muscle and you've got a very thin, paper-thin capsule that is like tissue paper thin, taking it off from the anterior surface, which is underneath the pec, is kind of easy, because there's a plane between your implant and the bottom of your pec, right? But then the problem that you're going to face is, if you have a thick capsule, easy to take it off the rib cage. If you've got a super thin, paper thin capsule that's on the rib cage, which has, ribs go like that, and there's a gap between each rib, and you've got intercostal space, and there's a few muscles, and then you're into the rib. If you're trying to take a paper thin bit of tissue off the posterior capsule, off the rib cage, you've got a risk of a pneumothorax, which means a hole in the lining of the lung. You're going to have rib pain, and you're going to cause bleeding. So in cases where it's definitely clinically needed, capsular contracture, ALCL, of course you do a full capsulectomy, because there's a scientifically proven clinical benefit from doing it. However, in cases where you don't know if a capsulectomy is going to make any difference or take an implant out, then you don't do something that can cause more harm. So there's an absolute risk of pneumothorax, there's an absolute risk of bleed, but there's only a hypothetical improvement that symptoms will improve, and it's just not worth the risk of doing it. So that's where the en-bloc capsulectomy debate rages on. We're surgeons, we like operating, but you want to operate for the right reason, and you don't want to do it at the detriment to someone's health if you cause a puncture in the hole in the lung. So in summary, capsulectomy en bloc is very straightforward if you've got a thick capsule. You can take it out very easily. But in super thin capsules that are barely existent, it's really hard to take out because of the destruction that it can cause to the surrounding tissues. Sometimes you almost have to do a near mastectomy to get the capsule off the breast tissue. Do Instagram TV for the video. It's a good idea. I'm kind of running out of questions. This has been good. Fire away any questions you have. But yeah, I will put it on Instagram TV. That's a good idea. Maybe we'll save this video and edit it so I don't have to bang on about it again. Any other questions? What else can we talk about? Smoking, I guess, is a big one. Smoking and breast lift or breast reduction is important not to smoke. It's not just the smoking that's the issue, it's the nicotine. So breast implants by itself is not an issue. You make a 2.5 to 4 centimeter incision, you're not relying on wound healing as much, okay? But when you breast lift an implant, breast reduction, tummy tucks, when you're relying on blood supply, you're trying to make something tight. When you make something tight, tummy tuck, arm lift, when you make something tight, it shrinks or puts more force on the blood supply. So you need as much blood to get to the tightest bit. So in a breast reduction, and it's down here, the T, and the tummy tuck is right in the tightest spot, underneath the belly button, just above the Mons area. So you need blood supply. Now, nicotine shrinks blood vessels, so you need blood supply to heal it. So if you're on any nicotine, patches, gums, smoking, that affects your wound healing. So the science suggests that you need to abstain from all nicotine products 3 weeks before surgery, and you continue it 3 weeks after. So that 4 to 6 week window, so you've got as much chance of wound healing as possible. Because if you don't, there's a chance of infection, so implants get rejected, and also the nipple may not survive, and that's when you get nipple necrosis or a dead nipple. Are you still performing BBLs? Yes, only when asked by patients, and usually as an adjunct to another operation, such as a tummy tuck. I think it's a good operation when done conservatively, but the big BBLs, the big Brazilian butt lifts that you see when you go to conferences in America, my concern with them are, besides the fact that you can get fat embolus and patients can die, which is actually a pretty big deal, is I don't know how well that fat is going to age with time. You go to conferences and patients put in 1,000 cc's on it, doctors put 1,000 cc's each side. I don't think that's going to look good in a few years' time. That's just my personal opinion. Here we go. Breast reductions. Yeah, I guess, actually, that's a good question. What is a lift? What is a reduction? The reality is lift and reduction is exactly the same operation, surgically speaking. A reduction, you're just removing more tissue. So in a breast reduction, you're trying to do three things. You're trying to reduce the breast volume, you're trying to reposition the breast higher up, and you're trying to reshape it. Same goals in a breast lift. You're trying to reduce the skin envelope, not as much breast tissue. You're trying to reshape it, same thing. And you're trying to reposition it higher on the chest mound. So you're doing lift it because you're using the same technique, same incisions. The only real difference between a reduction and a lift is a reduction, you're removing more breast tissue, but you're still lifting it. Because if you just reduce the breast tissue and just let it still stay low, no one's going to be happy. Do you do full tummy tuck, breast lift and arm lift at the same operation? Yes, I do. So here's the thing with that particular operation. I think they're all I would always do tummy and breast together because they complement each other. But also when you do a tummy tuck and you tighten the tissue, see how this shirt gets pulled down? It brings the breast down as well. So I do the tummy tuck first and then do the breast lift on top of it, and you'll see that you have to do less of a lift when you do a tummy tuck, in my opinion. So you definitely do those two at the same time. Now, do you add the arm lift? It adds an extra 2 hours. I have no problems adding the arm lift. The problem with adding the arm lift becomes a Medicare problem. Breast lift by itself can be covered by Medicare. As soon as you put an implant in, you can't use your private health fund, so which is fair, that's gone, you can't do it. Tummy tuck in extreme cases where you qualify to use the tummy tuck Medicare number, insurance companies will cover. And that's if you've lost a certain amount of weight, you've got stable weight, and the skin excess is so much that it folds and causes skin irritation. And if you can do that, then that's totally fine. Arm lift, similar if the excess skin gets in the way of daily activities and causes skin problems. However, if you want to use your private health fund, you can't combine the tummy with a thigh or an arm lift. So as soon as you want to combine those two, whilst surgically it's not a problem, financially it becomes a problem, because then you can't use your private insurance for arm or the tummy because they cancel each other out. So when it becomes a financial decision like that, it's better to stagger it, do the tummy and breast in one operation, come back and do the arm lift as a second operation, because all the hospital fees will be covered as long as you're eligible to use it. Can I do breast BA, BL at the same time or wait post BL? Thank you for that. Oh, okay, yeah. So I guess, thanks for that question. The question was, do I do a breast implant at the same time? Essentially, what the question we answered previously, which was, whether you should do a 1-stage or 2-stage breast lift and implant. My opinion is do it all in 1 stage, because it saves the second operation, and depending on the risks, so some patients have an easier breast lift, some people have a harder one. But if you do a 2-stage operation, it's 100% chance of 2 operations. But in my opinion, if you do it in 1, you can get it done in 1, and depending on the complexity, sometimes the revision rates are as low as 0. But I say to patients, sometimes it's 10 to 15% chance of a second operation, sometimes 50 to 70%. But I think it's better to do it in 1 because I can customize my lift to my implant. The problem with doing a lift first is you've done the lift based on whatever decision you've made to do a lift, but it's not customized to the future implant. So if, let's say you do the lift and it's super tight, then you've snookered yourself because you can't put a big implant in, because if you've got a really tight lift, then you can't put a big implant in. So then you can only use a certain implant. Or if you've done a lift that's really big, then you try to put a small implant in, and it's a total waste of time. So my thoughts are doing it all in one go allows me to customize my lift to whatever implant. Because as I said before, like a lift with this implant is going to be totally different to a lift with this implant because of the size mismatch. A lift with this implant I'll need to remove more tissue because it's smaller, whereas a lift with a bigger implant needs a smaller lift. So yeah, do it in one go, but you got to accept that there's a chance that you'll need a revision. Stretch marks common after breast augmentation. Yeah, that's a good question, as most are, because I got asked that again today. Stretch marks happen for so many different reasons, and a lot of it is stretch marks in general. So post-pregnancy, post-weight loss, post-weight gain. And a lot of it is the sudden growth of tissue. So you see it in men people that suddenly take anabolic steroids and they get big quickly, and men get their stretch marks here because they got too big too quickly. Then the same for women would be pregnancy, putting on weight, losing weight, both in men as well, I guess. So a lot of it is unlucky, but a lot of it is how quick the breast expands. So after breast augmentation, it's pretty rare to get it, but it can happen. But I think it's depending on how big you go. If you go really big in the first operation, of course you're going to get stretch marks. Of course you're going to have a high chance of stretch marks. For people that don't understand what stretch marks are, we all know what stretch marks look like, but why do you get stretch marks? Think of the skin as that thick, and the skin is made of the epidermis at the top layer of epidermis. So when people go, I've got a superficial burn, that's when the top gets burned. When then they go, I've got a third degree burn, that's when the top goes, and then the dermis goes as well. And you got, thickness of dermis. And in your dermis, you have elastic fibers, and that allows skin to recoil. Okay, so if you've ever cut your skin, the wound gapes open. Why? Because of all the elastic fibers in the dermis ping it open. Stretch marks, as the skin expands quickly, it destroys the elastin in there, so that skin's lost its recoil. Okay, so when it's lost its thickness and recoil, when you look into it from up top, because it's cross-section, when you look at it up top, it looks a little bit translucent. So the stretch marks you see are the cracks in the dermis and the elastic. And whenever you've got stretch marks, particularly if you've got stretch marks in your breast or tummy, and you want to do minimal operation, such as, I might try to get away without a tummy tuck, maybe liposuction or two. As soon as you've got the stretch marks, you've lost that ability for it to snap back. So in those cases, it's better to do a skin tightening procedure. Cool. Okay. Hi, everyone. This is kind of fun. This is my first Facebook Live. It's pretty cool. Okay, so what else can we talk about? There's no real questions. Lifting implant we talked about, breast reduction we talked about, nipple size we've talked about, picking the implant we've talked about, combined operations I think we've briefly talked about. I think as a rule, tummy and breast you should do together. Here we go. At what point do I make the... Okay, so I'm just trying to get the question. Okay, yeah, that's... so at what point do I make the first consult to have full tummy tuck and breast lift? I still have 12 kilograms to lose, or should I wait to get my goal? I think having the consultation can't hurt. It's best to have 2 consultations, so it's actually not that unreasonable to have the consultation now during the weight loss journey, just because then you've got a longer lead period to ask questions to get to your goal as well. But then once you've lost your weight, then have the proper sizing conversation and sizing the implant. What you don't want to do is hitting moving targets. So if your weight is going down like that, and you're here, you've got another 12 kilos to go, you definitely don't want to operate here. Even when you get to here, you want your weight to be stable, because you just don't want to hit a moving target, because what if it's going to go down some more? So that the conversation you have anywhere in that journey, but you only have the surgery, 3 months after you've lost the weight and you have stable weight. Lower body lipectomy. Okay, yeah. Lower body lipectomy, it can mean so many different things to so many different patients. So I'm assuming you're not referring to legs and you're referring to tummy. So I guess tummy tucks can be, you can have a normal tummy tuck, extended tummy tuck, and then belt goes all the way around. So I guess that is a lower body lift or lower body tummy tuck. And then you can have variants of it where you have a corset where you make the incision across here, so you've got a vertical scar, and the one that comes all the way around here. So that's kind of the options you have available for a lower body lipectomy, depending on where you have excess. My thoughts are, where possible, try to go all the way around, because that's the best way to get. Because what you don't want to do is get a flat tummy and then when you sit down have the excess here, because that really frustrates. So going all the way around where your belt is allows you to get as much of that lower body skin, and that will get rid of anything in the lower abdomen. If you've got any excess here, if you've lost massive weight after bariatric surgery, you may have seen on my Instagram page, I post a lot on, actually I did tonight, on Corset Abdominoplasty. And the corset's fantastic, because if you sit down and then you still have that excess skin, you need the corset. So what is a corset? The corset is an incision here, incision around here, and also incision in the crease, because this tightens that way, that tightens that way, and that tightens that way. So it's corseted close. Yes, it's a greater scar burden, but it's by far and away the best way to get as flat a tummy as possible when you've had so much excess skin. Hopefully that answered that question. Oh, here we go. I have 40-year-old implants. What's the chance of getting them out in one piece to replace them? Very high. Back to a question that was asked previously about en bloc. If you've had your implant in for 40 years, you've probably got a pretty well-formed capsule. So that's actually easy to get out in one block. Let's say it's ruptured, okay? Let's say, and it happens quite common, one side's ruptured, one side's not ruptured. When you've got a nice thick capsule, if you have if you've got a well-formed capsule, getting them out is very straightforward, because it's like this big cyst that comes out, because the body's created encapsulated this scar around it. So it's very straightforward to come out, and we don't even get to see the implant because you just take it out in one go. So if you look on my Instagram page, there's a picture of me doing one of those operations for a really old implant, and then off table I just cut it to show the implant. So having them in longer is actually easier to get them out than it is the other way, because it's all encapsulated. You take them out in one go. Here we go. I've had an umbilical and other hernia repair with mesh 24 months ago, but now want a tummy tuck. Is it possible without further complications? Yeah, I don't see why not. Depends what sort of other hernia repair you have, whether it was all midline. That tummy tuck is just you're cherry picking the area of skin you want to remove. So a lot of time patients have had like a vertical midline cut to get access to hernia repairs, but more and more these days general surgeons are using laparoscopic techniques. So yes, it can be removed at once. Now, one of the issues with doing a tummy tuck when you've had an umbilical hernia repair is the blood supply to the belly button, and whether that's going to survive the move. Because when we do a tummy tuck, we lift up the skin, say that's the belly button, we isolate the belly button, lift the skin up, tighten the muscle, pull the skin down, and make a little hole for the old belly button through a new hole. If you've had a hernia repair, we're just a little bit worried about the blood supply to that belly button. But if it's 2 years ago, 24 months ago, the blood supply is going to be pretty robust, so I don't think that should be an issue. And regarding the mesh, well, it depends where the mesh is. If they've done it laparoscopically, they've put the mesh behind the muscle, so we're not even going to see it. If they've put it on top of the muscle, then depending on what sort of mesh it is, you either leave it. If you want to tighten the muscle, do the muscle tightening, then you can't do the tightening if there's mesh in the way. So you may not be able to do the muscle tightening, but it shouldn't be an issue because you've got the mesh to support the tummy anyway. So yeah, I don't think that's an issue. Here we go. Okay. Do you recommend breast implant over fat transfer when I have a fair bit of fat to control? Yeah, okay. Yeah, so I think like that's such a real world question. The question is, I've never done Facebook Live, so I don't know if you guys can see the questions. But anyway, do you recommend breast implant over fat transfer? Because you're worried about two things: having an implant and getting breast implant illness, and two, doing the fat and not getting fat retention. So I guess that's the problem. The issue with fat, as I said previously, fat's great, in my opinion, as an adjunct to something. So you've done a breast lift and you don't want an implant, but you've done the lift and you want a bit more volume, so you do put some fat in the breast, like as an adjunct. It wouldn't do a good job as a lift by itself, but you've done the lift and you want a bit of fat, and that just helps fill, because you don't want implants. Or if you put an implant and you just want a bit more fat around it to try to give it some, more of a natural look. So it's good as an adjunct. But as a primary source of augmentation, as you kind of alluded to, the retention is unpredictable. So it's really hard to say to a patient, I'm going to give you 300 cc's of fat and only half of it survives. You're like, well, what's the point of having a 150 cc augmentation? 150 cc's is, that's 180 cc's. That's like, and put it into perspective, that's only a 300 cc implant. That's a 180. Look how much smaller it is. So it's such a small augmentation, and it's not that predictable. So I would go for the more predictable operation which is augmentation. And regarding breast implant illness, I think, as I said previously, whilst the science, and there's a lot of science on it, doesn't believe that it exists, it's naive to ignore all the patients, particularly on some forums, that suffer from it. So what is the cause of it? No one knows. Does it exist? No one knows. I think we're very much in the infancy of it. We can't ignore it, but we need robust science to try to prove it. What I'm considering doing, and I've talked to some of the research students at the hospital, is I have to find a validated questionnaire. I'm going to try to go through all my breast implant patients and ask them questions about breast implant illness, and then prospectively I talk to patients beforehand to fill out the survey, and then do it in a year's time and see on my patients whether it exists or not. But in the process of trying to get a proper validated questionnaire, which is not that easy to do. It's a bit annoying. You had keyhole surgery. Fantastic. So yeah, if you've had keyhole surgery, then you don't really need to worry. So this is the question about umbilical hernia and hernia repair. If it's all keyhole, then all the hernia repairs are deep to the muscle layer. So to go through the layers, you've got skin, then you've got fat, then you've got the sheath on top of the muscles, then you've got your muscles, there's layers of muscles, then you've got another sheath behind the muscles, then you've got the peritoneum that holds all the bowel organs in. So when you go laparoscopically, a keyhole, you're going through into the bowel area, and then so there's your layers like that. So skin's up the top, peritoneum's here. They go this way and put mesh across here. So we don't even get to see the mesh. They pull all the fat contents and all the bowel contents down, and if you've got a hole there, they just put a mesh on it. So we're up here, we're doing everything on the superficial level. It's not an issue at all. We would never even see the mesh. Oh, okay, Trish, you can see the question. There you go. Smiley face. Thigh lifts in the groin, incision or small vertical. It really depends on where the laxity is for a thigh lift. The problem, whilst we'd always like to, I'm going to stand up. Whilst we always like to make the incision there, the problem when you're trying to do it just in the crease, there's not much of a lift. You can only lift a little bit. You know, you're taking out a melon size, no more than 5 centimeters. And the more you try to take out in that melon slice technique, the bigger risk you have of a tight closure, which means that the labia majora can drift outward, which is a total disaster. So when you're doing a thigh lift, a lot of the excess the patients have is width and its laxity in that plane. So that's why you need the vertical with a little horizontal afterwards where the seam of my trousers are. Because standing up again, in that plane, you can remove, I've removed, like I did one on Friday, up to 15 centimeters. But here, you can only remove at most 5 centimeter width. So the pull from a groin incision is nowhere near as powerful as if you do the vertical. But the problem with the vertical is you've got the vertical incision, halfway down the leg above the knee. And that's why thigh lifts are such a pain, because you've got that scar that's on view. But it's more powerful at getting the inner thigh cleavage because you've cut out and liposucked more tissue. Kind of like the corset tummy tuck. Why I like it is when you do a traditional tummy tuck, you're only removing that much. But if you've got loose skin everywhere, if you remove all of that as well, it really helps because you're removing more fat and skin. Okay, here we go. So most of your photos show incisions in the crease. Your skin keloids, is there a chance of placement of incision so you don't see the keloid? Look, if you're going to get a bad scar, keloids are pretty rare. So proper keloid, because there's keloid scars and hypertrophic scars, and they're totally different things. So a lot of people that think they've got keloid actually have hypertrophic scar, and hypertrophic scar just means thickened scar, thickened and raised. True keloid is if you've got an incision like there to there, and then the scar extends over, or not that much, but extends past the boundaries of the incision and gets thicker, classically in the ear classically shoulders, classically in the sternum area, and has a racial predominance, Asian, Afro-Caribbean, subcontinental skin. So if you have a propensity to keloid, that's one thing, but if you've got hypertrophic, then there's techniques we can do to try to minimize it, such as cortisone injections at the time of surgery. But most importantly, you want to put the scar in a conspicuous spot. So in Australia, the most conspicuous spot is in the crease, because the armpit scar, if you're going to get keloid there and there, in Australia, where lots of singlets, you can see that. So you'd rather it somewhere that it's hard to see if you're going to get a, bad scar. Around the areola has a higher chance of hypertrophic scar as well, because you're going through infected tissue, you're going through breast tissue that has bacteria, so you've got an increased chance of infection of your breast. So the incision in the crease is the best, because when the breast kind of drops a little bit, it's hidden better than all the others. Plus, you're not going through breast tissue to get to it, or underarm tissue and all the bacteria that are associated with both. And also you've got the best view, because the pec muscle is different on every patient, and it's really hard to go from the crease and release the pec muscle down here properly compared to making the incision here. So that's why I choose the inframammary crease. What are the benefits of tummy tuck on bladder incontinence and back pain? I guess that's a very topical one. January 2018, so a good 19 months ago, Medicare took away tummy tucks from the MBS scheme. So historically, if you had a pregnancy, you could use a Medicare number. Now the only way you can use a tummy tuck if you've had massive weight loss and you have excess skin. And a submission has been made to Medicare, and some great plastic surgeons in Australia actually wrote a paper that was published in the International Plastic Surgical Journal, showing that it can help with bladder incontinence and it can help with back pain. So that paper has been submitted to Medicare for a review of the Medicare item number. So with knowledge of that paper, hopefully Medicare will allow tummy tucks to be done through the private health system. So I think there is a benefit from it, based on the papers that were just published by some Aussie surgeons. Where am I located? In East Sydney, so just eastern suburbs of Sydney. Currently we're in our temporary offices in Edgecliff. Previously we're above East Sydney Private Hospital, and we're just building a new practice in Surrey Hills. We were lucky enough to buy an old heritage listed church, and we'll start building and refitting it in a week or two's time. So hopefully be in the new digs, hopefully January next year, depending on the builders. What is my Instagram name? So it's just drmoradi.com.au. So drmoradi.com.au. And I guess, there's a lot of questions that people have asked, so I will do that Instagram TV and get it on the feed as well. Do you do breast lifting implant one stage? What is advantages and disadvantages? I feel like I've been through this, but I'll go through it again because it's, I guess, such a hot topic. I do breast lifting implant one stage because... Would someone read? Oh, okay. I don't know. Okay, let's start again. So, I do breast lifting implant one stage. Why? Because if you're going to do it in two stages, that's 100% chance of two operations. So there's 100% chance you need a second operation. And what do you usually do? You do the lift first, let it settle, 6 months later, put the implant in. Now, in some cases, you have to do it two-stage. They're the extreme cases. But like 90% of the time, 95% of the time, I do it all in one stage, but I stratify the risk to the patient. I say, look, chances are you won't need a revision, but depending on how difficult the case is, sometimes say there's a 10 to 15% chance you need a second operation, because I put the implant in, do the lift around it, and it's going to sag a little bit. Now, say if this sags a centimetre, but the other side doesn't, then you're going to have asymmetry. So the second operation is usually just a retightening procedure, because you've made it tight and it's just sagged a little bit and you just have to make it tight again. The chances of that, depending on the complexity of operation, I say to patients, from 10 up to 60%, but it's still better than 100%. Now, the most important reason why I do it, yes, it's one operation, but if you do your lift first, and if you do the lift too tight or too well, whatever word you want to say, then it's a great lift. You're super happy, but the problem is now you're short of skin, and you may have snookered yourself, because you might not be able to put a big implant in. You might only be able to put a small implant in. So your second operation, whilst it's easy putting an implant in, you may have snookered yourself. You might not be able to put a big enough implant in, or vice versa. You've done your lift and it's too loose, then you have to put a big implant in to match your lift, or then in the second operation, when you put the implant in, you have to redo the lift anyway. So what's the point? So I think my thoughts are, put the implant in and customize your lift at the time of the implant. So as I said previously, a big implant needs a smaller lift, less tissue taken out. A smaller implant needs a bigger lift, more tissue taken out, to try to get the same result. So yeah, one stage. Okay, well, the advantages, as I said, one operation. The second operation is usually a tightening one. The disadvantages of a breast lift and implant in one stage is having a revision, but still better than 100%. But also in difficult cases, you have a higher risk of getting infection and nipple necrosis, which when the nipple dies, and wound breakdown, because you want to make the lift as tight as possible. But if the lift is too tight, then you can't stick an implant in. So it's a juggling act between the two. Where are we up to? Is getting a breast lift before having kids pointless? Will they just go back to where they... Yeah, probably. I think so. If you're thinking about having kids, even before implants, I wouldn't. If you're going to have kids in the next year or so, I wouldn't even get implants before then. But I definitely wouldn't do a lift, because you may need a lift afterwards. The reality is, some people, like I saw a patient today, and it was like she had her implants, then got pregnant. And I said, as I looked at her, I said, "Oh, you wouldn't even know that you've had a baby, because you don't look like you need a lift. You look perfectly fine." So some people, it just depends. In between pregnancies, it changes, as most mums out there know. First pregnancy, no change. Second pregnancy, breast got big. Next pregnancy, breast got small. So it's so varied. But what you want to do is not hit a moving target. So whatever you decide, do it once you've finished having your kids, once you've finished breastfeeding, once you've finished losing your weight, so that you have one operation. Do I do mummy makeovers? Yeah, sure, absolutely. Breast lift, tummy tuck, I'm considering corset lift, maybe a body lift, back lift and thigh lift. Oh yeah, well, congratulations on the 60 kilos. That's impressive. So as I kind of briefly talked about before, I love the corset, because the corset will do your back lift and all your tummy tuck in one operation. So that's beneficial, because you're tightening here, you're tightening here, you're tightening here. So you're skin out there, skin out there, skin out there, brings it all in. So the corset takes care of that. And then you would combine the corset with the breast lift. Why? Because I like operating the chest and tummy at the same time, because once you move one, it affects the other. So you want to do the lift, do the corset, that's all tight, and then you do the lift on top of that. Don't forget, in the corset, you've already got that incision, which is the bottom half of your breast lift incision anyway. So you do both of those at the same time. And then would you do the thigh at the same time? Thigh and arms, you'd probably stage it and do the thigh and arms at a separate operation. Breast lift takes 2 hours, corset takes 4, so that's 6. Thighs take about 2.5, arms take about 2. So you really don't want to be asleep for 10 hours because of the risk profile. And Medicare did a very sensible thing and said, for multiple item numbers, you can't combine a tummy with an arm or a leg, a thigh lift or an arm lift. So if you have private health insurance and you want to use it, you have to put the thigh and arms as one operation on a separate time, because you can't do the tummy with those two numbers. The two item numbers clash, so you can't do them at the same time. So in your particular case, corset and lift in one, then come back and do the thigh and arms in the second operation. Here we go. Breast implant illness. Yeah, okay, cool. Yeah, I think you're right, Monique, with that question. What are my thoughts on breast implant illness? So you've been diagnosed with fibromyalgia. I guess it's hard to know. It's like the chicken and egg sort of thing. Did you have fibromyalgia, which is a common illness anyway? People without implants get them as well. Which came first? So, as I mentioned previously, in our latest journal, in our latest World Journal, they've looked through all the evidence on breast implants in relation to offspring, whether it affects childbirth, connective tissue disorders such as fibromyalgia, and cancer risks in that. And there's scattered evidence to support some, scattered evidence to support other. There's no one proper scientific paper that excludes it, but yet again, there's no real scientific paper that says that it exists either. So whilst the scientific data is sketchy and there's been 40 years worth of information on it, we still don't have a yes or no answer. But you can't exclude patients that feel better after implants come out. So I guess the decision you need to make about the fibromyalgia is talk to your rheumatologist and your immunologist and get him or her to confirm that you got fibromyalgia. So if you get testing, ANA testing or specific markers, and it says you have fibromyalgia, well, you have fibromyalgia, it's not related to the implant. Because what patients have done is not get those tests, get the implant out, still have those symptoms when they actually had a proper diagnosis of fibromyalgia, which the rheumatologist or the immunologist can diagnose with blood testing. The problem becomes when all those tests come back as clear, and so you don't have any of the inflammatory markers, any of the markers, then do you take the implants out to try to stop the muscle aches? Good question. It would be a coin flip if I try to guess. So I don't know. Okay. No. Oh, okay. Yeah. So back to one of your questions. No, not implants, just a lift. I don't want kids for another 4 years. Yeah, I guess if it's 4 years and there's no kids on the horizon, then yeah, you'd get the lift. Because don't forget, if you have to redo the lift, you're just using the same incisions anyway. So let's say you have kids in 4 years, have 2 kids, 3 kids, they're going to be separated by 2 years. That's still another 10 years away. So you'd probably have the lift now if you think you need it. And then once you finish kids, which will be in 10, 12 years time, then you may need a revision lift, who knows. Okay, I think I've answered that about you're 23 years old and you've had, yeah. It sounds like you probably need more of a breast. Well, we talked about lift and reduction. They're pretty much the same thing. Lift only lifts the breast and reshapes it and reduces skin, whereas a reduction does the same, reshapes it, reposition it, but you're reducing more breast tissue rather than just skin alone. I see it's flared up since implants, hun. Yeah, so I guess that's a very good point. So for 10 years it's flared up. I mean, I'm not an immunologist or what was the other one? A rheumatologist, but they'd be the best person to answer that question, where the cause and effect of it. Is it possible after just a normal tuck to go back and change it to a corset? Yeah, yes it is, because the tummy tuck has this incision down there. The corset is that incision as well as that one. Plus, once you do all that, you'll have to revise the tummy one as well. So yeah, it's actually totally fine to do. The only problem with the corset, it's just a bigger scar burden because you do have that incision. But patients that have lost 50, 60 kilos, they'd rather have a flat tummy than worry about scarring, which does fade over time. So that gets hidden, the incision down the bottom gets hidden, it's just that vertical one. And I guess the only time it becomes an issue is when you're hopefully wearing a bikini, but by then hopefully it's nice and the scar's nice and white and you don't get to see it. But for me, yes, it's a bigger scar burden, but you take flat tummy any day. So I got to... Yeah, what are the results of sole breast lift without implants? It just comes down to how much breast tissue there is in the breast. Because if you've got nice glandular breasts that just happen to have dropped for whatever reason, you've got breast tissue to work with. So internally we reshape that breast tissue, create a nice mound, and then do the lift around it. A lot of the times if you're totally deflated after pregnancy or weight loss, there's literally just skin. There's no internal breast tissue to shape. So it's really hard to create shape when you've got nothing to create shape with. So the lift, the success and the aesthetics of a lift are pretty much dependent on what breast tissue you already have inside. Good. Okay, hey Tez from Gladstone, remind me what operation, how long stay in Sydney, wait. Oh, okay, yeah, the big one. Yeah, the big, Corset, big long operation. You'll be in hospital so a lot of patients that fly in for this major body contouring surgery, they're in hospital for 5 to 7 days anyway. So what I say to patients, you're in hospital for a week, you're going to be discharged when you're totally 100% ready. If you live down the road, we'll probably discharge you 3 to 5 days, but if you're coming from out of town, try to keep you in for a week in hospital, and then try to keep you in for another week post-hospital in one of the local hotels, or if you've got friends and family, just so that you're totally recovered, and if there's any hiccups or any issues, if you're going to have an issue, you have it in the first 2 weeks, or first week really. We want to make sure you're local for that. Okay, yeah, so the Instagram, Facebook page. Instagram page is drmoradi.com.au, so drmoradi.com.au. And I think I've got a Facebook page. I haven't been on Facebook for a while, but I think the Instagram's linked to the Facebook page. And then I've got a practice page as well with my business partner, Dr. Alex Poon, and that's Park Clinic Sydney. I don't know what the Instagram page for that is. Give me a sec. So the Instagram page, for the Park Clinic one is just Park Clinic Sydney. And then the Facebook one's like drmoradi.com.au. So hopefully I'll help. I probably need a cooler Instagram name than my website, but the Dr. Moradi, that's my website address, so I just figured that'd be easier. Okay, cool. Here we go. I've had 3 cesareans all the time. Yeah, so that's a common question. Whenever we do a tummy tuck after someone's had a cesarean, we generally go a little bit lower than the cesarean scar, and all that cesarean, all the scarring down to the layer is all removed. Then the muscles are tightened on top of it and the skin is resected on top of that. So do you correct this as well during the muscle revision? Yes, that all gets corrected at the same time because all of it gets removed. Cool. Geez, we've flown by. It's been like an hour. What time do we start? 6:30, a bit after 8. So we've been through a fair bit. It's actually kind of fun. I can get rid of that. So I think all the questions were pre-asked. I've been through. So I can get rid of that. Yeah, cool. So, any more questions? Trish, what should I do? Just sit tight for a little bit. What else to answer? Breast massage, commonly asked question after breast augmentation. I never quite understood the science behind breast massage, but if it can't help, then you just if it can't hurt, then you might as well do it. The theory is I've never quite understood the theory, but when you're massaging it to try to soften it, to try to decrease capsular contracture, but if you're underneath the muscle, every time you contract your muscle, it does a massage. But my thoughts are to help soften it. It's not going to hurt, so you might as well do breast massage. Another common question is underwire bras after breast augmentation or breast reduction. Yet again, I have no problems with it. Never quite understood the science behind it. But some people, the underwire may irritate the scar. So, as with most things, you just do what's comfortable. If it hurts, then you don't do it. So you wear an underwire bra when it's right to wear it, and it feels comfortable. Then yeah, go for it. It's not going to hurt. I've just had my 4th baby, but first with implant. So it's unlikely. Well, it depends which access your surgeon used to put the implants in. If he or she went through the breast gland, then yes, you may have scarring around the breast glands that could be causing this. The reality is women with or without implants or with or without breast lifts have duct problems that causes mastitis anyway. So it's hard to know whether that's caused it, but the implant should be well away from the breast gland, so it shouldn't cause it. I'm looking at getting them out and I'm wanting a lifting. Yeah, okay, I think that's not that unreasonable, getting them out and doing a lift that may be smaller. Yeah, that's pretty good. Cool. Hopefully it's been helpful. So I will... What time is it? It's like 10 past. Why don't we... It's nearly 10 past. Okay, it was 8 past 8. So why don't we chat for an extra 2 minutes? Unless you got questions, I can talk. I mean, they're really good questions. But yeah, if you've got questions specifically for me, I would go on my Instagram page and do a direct message or just email me. The best is email or Instagram. I'm pretty good with emails. I'll be able to return your questions. A lot of time patients like sending photos and I just give them advice. It's easier that way. What are the psychological components of this type of surgery? I think the psychological components are, depends which operation you're having. If you're having breast implants after breast reconstruction for mastectomy, there's a heavy psychological component to it, particularly if you're having a risk-reducing mastectomy and you don't have cancer and you have to go through the whole ordeal of a mastectomy, then implants become a pretty big thing because you're technically just removing a healthy object, a healthy object that's part of you, and replacing it with either another part of your body or an implant. So that has great psychological impact on a patient. In terms of plastic surgery, cosmetic plastic surgery, not plastic surgery in general, but the cosmetic arm of plastic surgery, the psychological components are more in any facial work. I think facial work has more psychological impact, and there's more cases of body dysmorphia and unhappiness with facial work. With breast work, it's less of an issue. The only patients I've sent to psychological evaluation for breast work is really the young patients with developmental breast asymmetries or tuberous breasts, or a 16-year-old patient, a 16-year-old female patient who's got J cup breast and needs a breast reduction. So anyone underage with developmental issues, of course, you get psychological assistance with. But generally speaking, for most other patients, it's not as necessary. What is the waiting time between surgeries? Good question. I think you would say 3 months would be the waiting time between those operations. Now, have I done it in shorter period? Sure. Have I done it in longer? Yeah, absolutely. But 3 months is 6 months, 6 weeks to 3 months is probably the sensible one, Tessa. Cool. But yeah, send me so my either email info@drmoradi.com.au or direct message me through Instagram. Do Instagram, not Facebook, because I'm not really on Facebook that much, but go through Instagram and I'll be able to reply to any private questions that way. So I think we can call it. Oh, no, here we go. Do you do consultation? Yeah. Yeah, for a lot of my patients are out-of-town patients and interstate patients, so we do consultations over the phone. Generally, as I said, patients send photos in, emails, and we've got a questionnaire that patients fill out. And then we organise a telephone conversation, or Skype or FaceTime, it doesn't matter. Usually it's better having the photo on a screen, and then we have a discussion over the phone, and then after that, one of the team will be in touch to organise a formal face-to-face consultation and surgery. So yeah, a lot of consultations get done online because for me to say, look, I'm a consumer and I want, when I want to buy something, I like to have access to the person that's providing it. So I'm pretty quick at responding to emails because that's how I'd want to be responded with. Cool. Okay, so I wish you all the best. Hopefully it's been helpful. I've actually enjoyed it, my first Facebook Live event. I want to thank Trish and Plastic Surgery Hub for arranging this, because if you hadn't done it, I would never have done it. So thanks for that, Trish. Shout out. And then hopefully be in touch. Hopefully that's been helpful. Thank you.